Hey everybody, it's Mr. Sim Guy back again with our next episode on reading and understanding bradycardic rhythms. Here we will break down several different types of bradycardias in a way that's easy to remember. But first, a quick reminder that bradycardia is defined as any rhythm with a heart rate less than, you guessed it, 60 beats per minute. There can be many causes of bradycardia, from a perfectly healthy athlete to several different conditions like heart disease or a myocardial infarction. There are also a host of metabolic conditions such as medications and thyroid diseases, so it's important with stable bradycardia that we search for and we treat the underlying causes. But in the unstable patient, it's important to treat the bradycardia. In many cases, if we bring the heart rate up to normal, we can alleviate some of the symptoms. So, what are bradycardic rhythms? Well, I thought you'd never ask. So, let's break them down into three categories. We have benign to symptomatic, potentially unstable to deadly, and the could be bradycardic or tachycardic rhythms. Asymptomatic and benign rhythms are those that the patient may have had for years and wouldn't know if a healthcare professional hadn't ordered or performed an EKG on them. Potentially unstable and deadly rhythms are usually symptoms of a dangerous underlying condition. And then there are the rhythms that don't fit into the bradycardia tachycardia rulebook, so we'll go through all of them. The most common bradycardia is sinus bradycardia. It appears with a regular rhythm, a narrow QRS complex, and a P wave before each QRS, but at a rate under 60 beats per minute. This can be a result of a strong heart, as in the case of an athlete, or as a result of a medication such as a beta blocker, which slow conduction through the SA node. It can even be a sign of cardiac issues, but most often it's benign. The second most common bradycardia is the first degree AV block. Wait, we can't start talking about AV blocks without understanding what they are first. AV blocks, or atrioventricular blocks, are a result of a conduction problem through the AV node. The SA node is doing its job correctly, but for whatever reason there's a delay in the electricity passing through the AV node. There are four types: first degree, second degrees, type 1 and type 2, and then third degree. As you would guess, they get worse as you go down the line. The first degree AV block is often asymptomatic and appears much like a sinus rhythm, but the PR interval is increased to greater than 200 milliseconds, or 5 small boxes on the EKG paper. Second degree blocks are characterized by a dropped or missing QRS complex. The electricity gets blocked through the AV node, usually in a pattern, and the difference between the two types can be seen in the PR interval. In a second degree type 1, also known as a Mobitz 1 or a Winky Bach, the PR interval increases until the conduction gets blocked, and then it resets to start the pattern over again. A second degree type 2 or Mobitz 2 also presents with a dropped QRS complex. However, the PR interval remains constant until the electricity gets blocked. This also presents in a pattern form like 3-1 or 4-3 or something to that effect. We have a couple of tools to help remember them. With a type 1, the PR interval gets longer, so we say longer drop, then you have a Winky Bach. With a type 2, the PR interval stays the same, but we have a drop, so we say if your R's do not go through, then you have a Mobitz 2. With a third degree heart block, the AV node is not conducting electricity at all, so the electricity coming from the SA node is not reaching the ventricles. Not to worry though, when the bundle of His realizes no electricity is coming, it generates its own, but at a much slower rate. The SA node is typically between 60 and 80 beats per minute, whereas the ventricles usually beat between 20 and 40 beats per minute. Both will be regular, but at two completely different speeds. To remember a third degree block, we say if your R's and P's do not agree, then you have a third degree. Okay, so that's the basics on AV blocks for now. We will get into the physiology in later sessions, but for now we'll get back to the bradycardias. So asymptomatic and benign rhythms include sinus bradycardia, first degree AV blocks, which we Potentially unstable to deadly rhythms include second, third-degree blocks, and junctional rhythms. A junctional rhythm occurs when the SA node stops working and the AV node, or the AV junction, takes over as the new pacemaker for the heart. This will present as a regular rhythm with a narrow QRS complex, with no P wave or an inverted P wave if the AV junction is strong enough to send electricity backwards to the SA node, and the rate will generally be between 40 to 60 beats per minute. The AV junction can speed up, causing junctional tachycardia as well, but it's rare. The next is the idioventricular or ventricular escape rhythm. This is when both the SA node and the AV node have stopped working altogether, and the bundle of His is taking over as the new pacemaker for the heart. This will be a regular rhythm with a wide QRS complex, no P wave, and a rate between 20 to 40 beats per minute. The last, of course, is asystole, the mother of all deadly rhythms. This rhythm has no electrical activity and presents with no P wave, no QRS, and no T wave, so it just appears as a flat line. Rhythms that can be anywhere from bradycardic to tachycardic include atrial fibrillation. This is caused when several cells of the atria start generating small amounts of electricity on their own, but not enough to cause depolarization of the atria, so they show up as fibrillation waves along the isoelectric line. This rhythm becomes irregular with a narrow QRS complex and no distinct P wave. The rate is determined by the amount of cells and the electricity getting to the AV node. Wolff-Parkinson-White syndrome, or WPW, occurs when the Henry's pathway in the heart does not completely close at birth, so electricity can bypass the AV node and go directly from the atria to the ventricles. WPW presents similar to a sinus rhythm with the presence of a delta wave in the PR interval. This is a swooping upward where it should be flat right in that PR interval. So that about covers bradycardias for now. In our next episode, we will go over acquiring and reading 12-lead EKGs. Once we do that, we can come back and go more in depth into bradycardias, physiology, and treatment. So until next time, don't forget to like, subscribe, and set an alert to know when the next video drops. See you soon.